afternoon, everyone, and welcome to our Young Investigator seminar series. Today we have a guest from Germany, from Munich. Her name is Sabine Weber. She was suggested by Alexander Gerbes, who is also here among the audience. And she's a doctor in the Department of Clinical Medicine too, right? At the Munich University, Munich Clinicum, right? So I give you, if you want, you can start whenever you want. Can you hear me well and everything?
Yeah.
Okay, perfect. So if you want, you can just go ahead and start.
Mm-hmm. So thank you all for the kind introduction. So my name is Sabine Weber, and as you already heard, I'm working here in the University Hospital in Munich. And today I was invited to give the talk on the current gaps and futures of DIli research. So you most likely all know this. DIli is quite a rare disease with an incidence that is estimated to around 14 to 19 per 100,000 persons per year. However, it is the leading cause of acute liver failure in the US and European Union, and it is also one of the leading causes for termination of clinical studies and the market withdrawal of already prescribed or prescription medicine. So DIli is rare, but it is a relevant problem, both in our clinical practice as well as in drug development schemes. And this is why it's really important to also identify it when it's there. And you all know this as well. If we are suspecting a DIli case, we need to go through a lot of different assessments and examinations, because in the end, DIli is a diagnosis of exclusion. So you need to exclude every other type of liver injury that could be causing this acute hepatitis. And so there are a lot of challenges here that we are encountering as the clinicians. So DIli has a really highly variable clinical phenotype. It can imitate a lot of different liver diseases. Also, when we're looking at histopathology, we know there's quite a lot of overlap, especially when it comes to autoimmune hepatitis. And so far, we don't have any diagnostic tests or biomarkers that are used in clinical practice. So right now, the current diagnostic standard is that we are using expert consensus opinion to diagnose it. However, here we have quite a high inter-observer variability and so far no external validation of this. And we also frequently encounter a problem because a lot of the patients that we're seeing with DIli are not only using one drug, but they're using different medications. So polymedication is quite frequent. And here the current recommendation would be to actually discontinue all of the possible causative agents. However, if we're talking about a patient that, for example, is having a tumor medication together with other medications or also herbals, for example, here it could have negative consequences if we're discontinuing the wrong medication, because then we would be taking away life-saving medications from this patient. We know that the best indication for that the drug was actually causing DIli is a positive re-exposure. However, this has quite high risks because there's a risk of a flare and possible also liver failure if we're doing this. And this is why here in Munich, we had developed a test, the so-called MH cell test, or monocyte-derived hepatocyte-like cell test. And this is a test that's based on patients' blood, and their monocytes are isolated, and then they're modified towards those MH cells and incubated with the possible causative medication. And as you see it here in the spider web, you have in some patients, you have peaks here, for example, in this patient with indomethacin, that can give you a hint that here the causative medication, for example, in this case was indomethacin and not the other ones, and that those other medications could be continued. And this test was actually validated also internally here in our center with a cohort of patients with positive and negative re-exposure. So the really good indication that DIli actually happened or not, and it was actually predictive of a positive re-exposure in 12 of the 13 drugs that was tested, and it didn't show any toxicity in none of the patients with negative re-exposure. So here quite a high sensitivity and specificity. Furthermore, if we're thinking about how to diagnose DIli, we should really be understanding what's happening if we're seeing DIli. If we want to identify some markers or some tests, we should know what we're looking for. So we should be thinking about the pathomechanisms behind it. And here we don't know everything, but there are some there is some evidence or some things that need to be considered. So, for example, we know there are some drug-related factors, for example, so drugs with high lipophilicity, higher daily doses, and drugs that are substrates of CYP440 have a higher risk to cause DIli. And we also know there are some host factors, for example, genetic susceptibility. So, for example, HLA association has been associated with higher risk for DIli. Also, for some drugs, there are risks, for example, age, female sex, race, or underlying diseases that can increase the susceptibility towards DIli. So further pathomechanisms that have been talked about are also mitochondrial injuries that are happening in DIli patients. So, for example, that while DIli is happening, that there is an inhibition of the mitochondrial fatty acid oxidation and also the respiratory chain, leading to disturbance of the mitochondrial membrane integrity. Also, there have been there's data that is showing that bile salt export pumps are inhibited. And for example, here there's was a study that showed that drugs that have a dual potency as mitochondria and also bile salt export pump inhibitors actually are associated with more severe DILIs and more restrictive product labeling on those drugs. However, this was later on a little bit questioned by, for example, this study here that showed that they are most likely, or those changes are most likely not universally predictive for DILI, because those authors found that the bile salt export pump inhibition was not associated with DILI potential, and they found that there was data demonstrating that the data that was demonstrating a correlation between those inhibitions and DILI were mostly based on in vitro studies using really high drug concentrations. And also we know that typical drugs that are known to cause mitochondrial damage, for example, metformin, are only rarely causing relevant liver injury or increasing the risk for liver injury caused by other drugs. So this is a little bit questioning those mechanisms. And nowadays we're thinking more about actually an immune reaction that is happening during a DILI episode. So most likely they are reactive metabolites and from the drug and proteins that form neoantigens, and through damage-associated molecular patterns, or DAMs, then antigen-presenting cells are activated, and those neoantigens are then presented via HLA, so human leukocyte antigens, on those antigen-presenting cells, and leading in the end to an adaptive immune response, and then to a T-cell-induced hepatocyte injury. So looking at all of this, there are some biomarkers taking from those pathomechanisms that we can think about. And for example, I mentioned it quite a bit, HLA has been associated with DILI. For example, the amoxicillin clavulanate DILI has been associated with different HLA class 2 and class 1 variants, and those HLA variants actually have a really high negative predictive value. So meaning that they can be used to exclude DILI by a certain agent. However, the positive predictive value is not as high, limiting this the application of HLA variants in the diagnosis of DILI. Furthermore, we can think about a little bit of mechanistic biomarkers. So looking at those mitochondrial damages that might play a role in the inflammation, especially the DAMs. Here are some markers that have been looked at in further studies. And for example, here in 2018 published in Lancet Gastroenterology and Hepatology, there was this interesting work which showed that microRNAs, and especially microRNA 122, which is hepatocyte specific, was elevated within hours of a paracetamol overdose. And if this microRNA 122 was combined with high mobility group box 1 and keratin 18, so here, this is a DAM, for example, as well. This showed a more accurate prediction of paracetamol-induced liver injury than ALT, so a traditional marker alone. And then this was one of the landmark papers published in 2019 in Hepatology, looking at candidate biomarkers for DIli detection and comparing those to healthy controls. And here the authors looked at traditional markers and then compared them, as I said, to candidate biomarkers, and they found that keratin 18, fatty acid binding protein 1, caspase cleaved keratin 18 and GLDH actually were associated with area under the curves of over 0.9, so really high associating with DIli detection, so that those would be actually biomarkers used in DIli diagnosis. And they then looked further at the correlation of those markers with ALT, and they found that GLDH and also the before mentioned microRNA 122 correlated well with ALT, although they found that GLDH actually correlated better with ALT than the microRNA 122, questioning a little bit the application of this microRNA in DIli diagnosis. And questioning this application a little bit further, they then also looked at those biomarkers in healthy controls. And they found, especially for microRNA 122, that this was actually quite variable in healthy subjects, between the subjects, so inter-individual, but also in the same subject, but at different measuring time points. So this is showing us here that actually maybe this could not be the best biomarker for DIli detection. So other biomarkers from the microRNAs were also proposed here in this, for example, study looking at microRNA 129, which is also a liver-specific microRNA, possibly could be used for DIli diagnosis. However, this has also been proposed as a marker for NAFLD progression, so maybe not as specific here. And one thing that we might be looking at in the future is more profiles of markers, and for example, here profiles of mRNA biomarkers. So in this study here, the authors looked actually at a profile of 37 microRNAs that could distinguish different types of liver injuries really well. So we see this here, apart from hepatitis B and NASH that were quite similar, all the other types of liver injury could be separated by this marker profile. And this is kind of an approach that's also been used in metabolomics. So here I'm showing you a study that used a metabolomic approach, also looking at biomarker panels. And these authors here found that 15 bile acids actually could be separate, or could separate DIli patients from healthy controls really well. And interestingly, they also found that 6 of those bile acids were also higher in patients with more severe DIli, showing that those bile acids might actually be also a marker for DIli prognosis. Also, there are some studies, a little bit older studies on proteomic approaches. I'm looking for biomarkers. One study from Munich here that looked at the cell adhesion molecule IgGB3, and it was found that this was actually upregulated in the MH cells, which I showed you before in patients from diclofenac DIli, but lower in the blood from those patients when compared to healthy subjects or patients with DIli due to other drugs. So a possible marker here that is could be used differentially in the blood or in the MH cells that I showed you. Also, quite an old study using a proteomic approach that found that apolipoprotein E could actually differentiate DIli from healthy subjects. Here you can see it with an area under the curve of 0.99, so quite high, and this diagnostic accuracy of apolipoprotein E could be even enhanced when it was combined with other markers or age, for example. And you see here it worked a lot better than ALT. So taking all of those information in, we can see that there's quite a lot of studies been done on the identification of biomarkers. However, we still don't have a biomarker or biomarker panel that can really help us in detecting DIli or finding the DIli diagnosis. There are no diagnostic tests that are in clinical use so far, and in particular, we need tests that can also identify the causative agent in case of polymedication. And in the longer run, we most likely will also need a more applicable diagnostic method that can also be used by non-DIli experts in primary or secondary care centers as well. So I talked about this a little bit in the introduction. It's really hard to exclude all of the other diagnoses when it comes to a patient with DIli suspicion, and this is especially true for autoimmune hepatitis. So when we look at autoimmune hepatitis and DIli, we also look at different scores, and if we suspect that the patient could have autoimmune hepatitis, we're using the simplified or the revised autoimmune hepatitis score, and one of the hallmarks of this score is autoantibodies. So anti-nuclear antibodies or smooth muscle antibodies, if they're elevated, they give certain points, and they give us a hint that the patient could be suffering from autoimmune hepatitis rather than DIli. However, it has also been proposed that those biomarkers could actually be assigned for DIli with autoimmune features or drug-induced autoimmune hepatitis, or that those antibodies could be associated also with DIli caused by specific drugs, for example, minocycline or nitrofurantoin. And this is why we looked at our DIli patients here, and especially at the patients that were tested for anti-nuclear antibodies, and those were 143 DIli patients. And we actually found that 67% of those patients were positive for ANA. And nearly 30% had ANA of 1 to 400. So this might seem really high. However, in our hospital, an ANA titer of 1 to 400 is the titer that is regarded as clinically relevant, where the laboratory then goes a little bit further and looks at the differentiation of the ANA. This is due, and if you go back, you see here in the autoimmune hepatitis score, there's a cutoff of 1 to 40. However, in our hospital, 1 to 100 is the lowest that can be, that is seen as positive. And this is because the ANA testing isn't universal. So it's really hard to look at different ANA titers and compare them, because different laboratories are using different methods and different cutoffs. So in our hospital, 1 to 100 is positive and 1 to 400 is regarded as clinically relevant. And when we compared the patients with negative or lower ANA titers to the patients with higher ANA titers, we actually didn't see any differences in the clinical and laboratory parameters. The only thing that we really saw is that the patients with ANA of 1 to 400 or higher received more corticosteroids, possibly due to the physicians thinking this was autoimmune hepatitis. However, the outcome was similar between the two groups, so the remission rates were above 80% for both of the groups. This is questioning a little bit if the ANA titers are actually giving us a hint to an autoimmune like DIli, or maybe just a bystander effect of the acute hepatitis in those patients. So further on, what do we do if we think a patient has DIli or autoimmune hepatitis? Well, if we're really unsure, we have international guidelines that tell us that we should start prednisolone and look at the response. And if the patient is responding, we should be tapering those corticosteroids. And then if the patient doesn't relapse, we know it was DIli. And if the patient relapses, we know it's autoimmune hepatitis, and then we should be treating it like this. So this kind of this kind of treatment method does have some risk for the patients or some adverse effects, because if we're treating an autoimmune hepatitis, or if we're thinking we're treating an autoimmune hepatitis, but we're really treating a patient with DIli, we might actually be using quite high dosages of immunosuppression that the patient doesn't need at all. And we might be treating the patient with long courses of immunosuppression and causing adverse events. On the other hand, if we're treating a patient, I'm thinking we're treating DIli, but the patient actually has autoimmune hepatitis, and we're tapering the immunosuppression too early or too fast, we might be causing another flare and also possibly a liver failure. So this is why here in Munich, we also looked at possible diagnostic criterions for differentiating autoimmune hepatitis and DIli earlier on. And we looked at in total 44 patients that received corticosteroids. And we found that if we looked at the autoimmune hepatitis score, for example, and the RUChem score, the sensitivity was below 60 for both of those scores for detecting either DIli or autoimmune hepatitis. Also, if we looked at the histological findings, the sensitivity and specificity was 73% for the separation of those two entities. However, what we did find is that if we looked at the ALT in the first week of corticosteroid treatment, so in the first 7 days after corticosteroids were initiated, the ALT dropped significantly faster in the patients with DIli when compared to autoimmune hepatitis. And when we used a cutoff of 9% ALT reduction per day, we actually had a sensitivity and specificity of separating autoimmune hepatitis and DIli of 77%. So this worked better than the other scores of histology and might be a possible early marker for differentiating autoimmune hepatitis and DIli. So seeing all those results, we can see that there is actually unmet needs when it comes to the distinction of DIli and autoimmune hepatitis. We don't have any biomarkers really for diagnosis and also not for prognosis after we start immunosuppression. We don't have any specific histological patterns, and I will come to this now. We don't have good treatment algorithms when it comes especially to the unclear cases. And I didn't go completely into detail of this because of the time, but we don't have a good understanding of the overlaps, but also the specific differences between DIli, drug-induced autoimmune hepatitis, and autoimmune hepatitis without cause of drugs. So I said it just now, I wanted to go a little bit more into detail of liver histology as well, and the role of liver biopsy in diagnosis of DIli. So this is also always a point of debate. Should we biopsy a patient where we're suspecting DIli or not? And here we have some data, what we're supposed to find. So this is a paper from 2011, which we are often referring to by Suzuki et al. That showed with 33 DIli patients and 28 autoimmune hepatitis patients, that if we're seeing cholestasis, if we're seeing neutrophils in the portal fields, if we're seeing lymphocyte infiltration, this is favoring DIli. On the other hand, if we're seeing plasma cells, rosette formation, emperipolysis, fibrosis, or eosinophilic cells, this would be more favoring autoimmune hepatitis. And it was also found that interface hepatitis, necrosis, and portal inflammation are both present in DIli and autoimmune hepatitis, but would be more severe in autoimmune hepatitis. And then further on, there was also by the DIli network a systematic evaluation done of nearly 250 patients with DIli. And here we've seen that in patients that had more hepatocellular pattern of injury, there was more severe inflammation, necrosis, apoptosis, lobular disarray, rosette formation. Whereas in cholestatic injury, it was more bile plaques and duct paucity. So we do know a little bit what we're looking for. However, we also see that there are quite some overlaps, especially when it comes again to autoimmune hepatitis. And quite recently, there was this paper published in the Journal of Hepatology that again looked at the role of liver biopsy in DIli diagnosis. Here from the DIli network, again, 50 patients, and they looked at how helpful the liver biopsy actually was in making the diagnosis. So here, 42 patients initially were high causality DIli cases, 8 low causality DIli cases. And then they looked at how helpful, as I said, the biopsy was, and the biopsy was judged to be helpful actually in 70% of the cases, and it also changed the causality score in nearly 70% in the cases. So the DIli likelihood in the causality assessment increased in 48% and decreased in 20%, and especially the diagnostic certainty could be changed from less certain to more highly certain in 38% of the cases. So showing as well that biopsy can help in the causality assessment of DIli patients. And this is an interesting study, not so recent, but still, I think, quite interesting, from 2015, also looking at different immune cells that are found in patients with acute hepatitis. And here, a comparison of immunoallergic DIli, autoimmune DIli, idiopathic autoimmune hepatitis, and viral hepatitis. And here it was actually seen that in DIli patients, the numbers of B lymphocytes and of natural killer cells were lower. Finding that we're usually not looking at when we're looking at histological patterns. And something that might be expected was that in patients with autoimmune DIli, but especially autoimmune hepatitis, the plasma cell infiltration was higher compared to patients with the so-called immunoallergic DIli. So those studies show us that still the need of biopsy during the DIli workup should be evaluated and might not always lead to the conclusion, especially when it comes to the distinction of DIli and autoimmune hepatitis. Maybe we need to be thinking more beyond morphological patterns, and possibly in the future about machine learned techniques as well. So now I talked a lot about the diagnosis of DIli, but I mentioned it in the beginning as well. Obviously, we also need to be thinking about the prognosis. So if we're seeing a patient that we're thinking has DIli, and we kind of want to know, and we want to tell the patient as well, what is the outcome of this patient? Will this patient recover? Will this patient need liver transplantation? How high is the risk of death of this patient? And here, there's also search for biomarkers that can predict DIli outcome. For example, a study looking at metabolic and immune pathways. And this study as well found this caspase cleave keratin 18, a biomarker that can be used as a diagnostic biomarker, as I showed you before, was higher here in the severe DIli group, so that this marker might actually be helpful in DIli prediction as well. And the office also found by multivariate analysis of the metabolic pathways that 31 metabolites showed a different expression in patients with more severe DIli, and those were primary metabolites from the bile acid biosynthesis and also from alpha-linolenic acid metabolic pathways. And when they looked at immune pathways, they actually found 5 cytokines that they proposed as possible biomarkers that showed a different expression between the severe and non-severe group. And when they took a model with those 31 metabolites and 5 cytokines, they really found a good separation between severe and non-severe DIli. So here, a possible approach of how to find a biomarker panel for prediction of DIli outcome. Also something similar, a work from 2013 that looked at immune profiles and the association with DIli outcome. And here it was found that 4 immune analytes, and those were comprised of interleukin 9, interleukin 17, PGF, beta, and RANTES, predicted 6-month mortality with an accuracy actually of 92%. And when it was combined with a low albumin, here the prediction of DIli outcome was even increased to 96% accuracy. However, those results from the study were then later on tried to be validated in a cohort of patients from the DIli network. And in this study, it was found that the only prognostic marker from the study before was actually RANTES compared with low albumin. And here for those 2 markers, the prediction of 6-month mortality had an accuracy of 83%, quite a high specificity of 91%, but sensitivity was rather low with only 39%. Moreover, the microRNAs that I have shown before as possible biomarkers for DIli diagnosis have also been proposed for prediction of DIli outcome. And here in this study, it had been found that microRNA 122 again, and also microRNA 4463 and pre-microRNA 4270 were associated with a worse outcome in DIli. And interestingly, From all of the subjects, none of the subjects that had a value above the median of microRNA 122 died within the 6 months. And when a model was used that was combined of microRNA 122 and low albumin, the 6-month mortality could actually be predicted with 100% sensitivity and 81% specificity. And now coming back to the study that I'd shown you before, from 2019, looking at candidate biomarkers. Here, it was not only looked at candidate biomarkers for DIli diagnosis, but also for DIli prediction or outcome prediction. And it was found that keratin 18, osteopontin, and macrophage colony stimulating factor receptor, as well as the traditional biomarker INR, were associated with 6-month mortality or a need for transplant, and that it was proposed that those were promising candidate biomarkers for the prediction of DIli prognosis. And the authors then went also further and looked at finding a model for DIli prediction using the MELD score and 2 candidate biomarkers. And they found that in cases where the MELD was actually high, so 30 or above, the risk for death or need for transplant was quite high. However, or in the cases that the MELD was quite low, so below 20, the risk for death and transplant was also low. So those cases were quite clear. However, in the gray zone in between, so MELD in between 20 and 29, the picture was not so clear. And here they incorporated 2 of those candidate biomarkers, so keratin 18 and macrophage colony stimulating factor receptor. And with this incorporation, they could also divide the patients and define the risk of need for transplant or death, and really increase here the specificity to 89% with still a sensitivity of 93%. So here, possible markers again for DIli prognosis. We also have traditional markers when we're looking at DIli prognosis. So the most traditional one that you most likely all know is the Heiss-Law. So here, bilirubin above 2 times upper limit of normal, ALT above 3 times upper limit of normal is showing us a risk for poor outcome and especially risk of liver failure or death. And this Heiss-Law has been redefined as well using instead of ALT or AST, whichever is the highest, as you can see here, and then divided by alkaline phosphatase. And using this new Heiss-Law, the specificity can be increased a little bit. And also there have been other scores that have been proposed for the prediction of acute liver failure or liver transplant, for example, the prognostic algorithm by Robles and from the Malaga group that showed that patients with AST of 17.3 times upper limit of normal and bilirubin of 6.6 times upper limit, the normal had the highest risk of acute liver failure or need for liver transplant. And for example, another score, the drug-induced liver tox ALF score, used platelet counts in bilirubin for detection of patients with risk of liver failure or death. However, all of those scores that we're looking at are always talking about how high is the risk to develop liver failure and or death or need for transplant. So far, we don't have any score that tells us how high is the risk of dying if a patient already has liver failure. And this coming from a transplant center can be sometimes quite important because we need to know which patient we need to be listing for high urgency liver transplantation maybe earlier on, and which patient we think might be recovering without liver transplantation. And this is why we looked at our patients that had drug-induced liver failure. So those were 33 patients, and looked at different scores or different laboratory markers that could help us to define which patient will survive and which patient will die or need transplant. And here we found in this cohort that as a single marker, actually a choline esterase, so something that is not tested really regularly, but here in our hospital, in those cases, is tested in the normal standard lab. And yeah, if the patient has liver failure, and we found that this choline esterase had the highest discriminatory power. However, when we combined choline esterase with MELD or MELD and platelet count, or if we combined iron alkaline esterase and platelet count, we actually could have quite a good distinction between patients that survived and those patients that died or needed liver transplant, showing that those marker combinations might give us a hint of when a patient has liver failure, will he survive or will he need liver transplantation? In addition to defining the patients that are at risk for liver failure or death, we also want to define those patients which have maybe the risk of developing chronic DIli or have a liver morbidity that is that will be with them in the future. And here the data is actually quite scarce. So first of all, we don't have a real definition for chronic DIli. We in some studies, we're talking about persistence of liver parameter elevation for 3 months and others for 6 and sometimes even for 12 months. And then if we're looking into the literature, we see that there have been some studies done, for example, by the Spanish DIli registry here, who found that out of nearly 500 patients, 6% developed chronic DIli, and this was more often in patients with cholestatic or mixed type liver injury. And also a study by Björnsen from 2009 found that out of 685 patients, 3.4 were actually hospitalized again for liver disease. 8 of those patients developed cirrhosis, 5 had cryptogenic cirrhosis, in which DIli might have played a role, and 5 also developed autoimmune hepatitis. And it was found that longer duration of drug treatment before DIli was associated with those liver-related morbidities and mortalities. So concluding this, you can see that there's also quite some effort done in identifying predictive markers or biomarkers for severe DIli. However, so far we don't have a marker panel that is used in clinical practice to give us the prediction how severe the DIli outcome will be. We also don't have any marker or marker panel for risk prediction in severe DIli cases already, or DIli with acute liver failure. And what is lacking is also studies with longer follow-up on patients with chronic DIli, and especially in order to know, is DIli really the cause of the liver morbidity or mortality in the longer run of the patient, or was DIli only a bystander and the patients develop liver cirrhosis, for example, due to other causes such as autoimmune hepatitis or NAFLD. So here there's more studies that need to be done. And now, as the last topic, I want to come to DIli treatment. So if we identified patients with DIli, we also want to help them recover. And for this end, sometimes corticosteroids are used. And I have shown you as well that especially if we can't exclude autoimmune hepatitis, corticosteroids are used. And there are different studies that have shown possible beneficial effects. Also, the study that I showed you that was done by us, where we found that AOT was actually reducing quite fast in DIli patients. But however, so far there are no randomized controlled studies on the use of corticosteroids in DIli patients. And in addition to this, there are also other studies that have found no benefit of corticosteroid treatment in DIli patients. For example, here the study looked at a severity reduction in DIli patients between patients that received prednisolone and that didn't, and they didn't find any severity reduction, and they did not find an improvement of overall survival when patients were treated with prednisolone. And also they saw that if patients were treated with higher dosages of prednisolone, so higher than 40 milligrams per day, and this is this group here, actually the severity reduction was lower when compared to the patients that were not treated with corticosteroids or that were treated with corticosteroids at lower dosages. And another study already from 2014 also looked at the effects of corticosteroids in liver failure. Here, liver failure caused by autoimmune hepatitis, DIli, or undefined causes, and they didn't see any improvement of overall survival. They did not see any improvement of overall survival in drug-induced liver failure. they did see that in drug-induced liver failure, the spontaneous survival, so without liver transplant, was better in the patients treated with steroids. However, when they looked at the sicker patient, so here at the patients who had MAUT above the median or the highest 25% quartile, they actually saw that corticosteroids were harming the patient with an overall survival that was a lot lower when patients were treated with steroids in comparison to the patients that were not treated with steroids. And going a little bit further, I also want to show you those the data that we have published last year from our hospital looking at methylprednisolone, so a different corticosteroid, not prednisolone. And what we found here was that actually methylprednisolone can also cause DIli. And you can see it, for example, in this patient here, a patient with multiple sclerosis, had a 3-day course, and just after the 3-day course, the liver parameters went up. And then we looked at our DIli database, and we actually found that 13 patients had liver injury caused by methylprednisolone, and we found a high predominance of females here. We found that those patients had a really high increase of ALT, so nearly 50 times upper limit of normal. More than half of the patients presented with jaundice as well. And interestingly, 10 of the 13 patients had a positive re-exposure, so had DIli episodes before the acute episode where we included them into our database. And even possibly even more interesting, if we treated those patients with prednisolone, so different corticosteroids, this was done in 8 of the 13 patients, we saw a rapid decline of ALT, and we didn't see any flare when we discontinued or tapered prednisolone. So somehow in the methylprednisolone group, prednisolone does help, at least in our small case series here. And as I said, what we saw a lot was actually a positive re-exposure. So, for example, in this patient here, which we included in our study at the 4th course, this patient had received 3 courses before, and every time the liver parameters went up, this time even quite high. However, the liver parameters went down, and the patient were never really or hepatologists were never really consulted, and methylprednisolone was given again and again. And this might actually lead also to liver failure, because we had also patients from our cohort that needed to be transplanted because of liver failure due to methylprednisolone. In addition to corticosteroids, there's also deoxycholic acid that is used in DIli treatment. And there's has been a recent systematic review looking at the publications talking about deoxycholic acid in DIli treatment or prevention. And here 33 publications were included. 8 clinical studies, 4 of those were looking at the benefit of deoxycholic acid in DIli treatment, 4 for DIli prevention, and 25 case reports. And it was found that 18 of the 25 case reports actually showed a beneficial effect of deoxycholic acid. And also from the 4 clinical studies evaluating the benefit of deoxycholic acid in DIli treatment, 3 showed beneficial effects. For example, here in a study that showed that nearly 80% had reduction of liver or had normalization of liver parameters, 18.5% had reduction of liver parameters, and only 4% didn't show any effect. And also the studies looking at deoxycholic acid in DIli prevention found possible protective effects in 75%. And it has been discussed that potentially the mechanistic effects behind this is the regulation of hepatocyte apoptosis, also membrane stabilization, antioxidative effects, and also immune modulatory effects. So here a possible treatment that could be used. But however, you see it from the data that I've shown you that we don't really have randomized controlled trials regarding the treatment options, especially when it comes to corticosteroids and use in DIli and drug-induced liver failure. We don't have any randomized controlled trials that can show us if they're beneficial or not. And if we're initiating corticosteroids, we don't know how fast we should be discontinuing them, how fast we should be tapering. And we have, so far, we have lacking data if we should be treating patients differently where we suspected drug-induced autoimmune hepatitis rather than DIli or autoimmune hepatitis. So with this, I want to come to the end and thank you for the attention. And obviously, I'm open for questions.
Okay, thank you, Sabine, for this very nice talk about especially the gaps that you have in the clinics to identify DIli and to really make it clear that it's DIli and not autoimmune hepatitis. Do you have any questions in the audience? Or I can start, maybe. I can start with a couple of questions. For example, these mirrors that you mentioned, 122 and then 129, they don't look to work well, right, at the clinic. So my question is, where are from which cells are they secreted? Are hepatocytic? So they are from hepatocytes. They are in extracellular vesicles. Because obviously, when you do a panel of mirrors using a microarray, you get a lot of a big number of mirrors, but some of them might be useless. So is there any physiology or mechanism of these mirrors?
So especially the microRNA 122 is thought to be secreted by the hepatocyte specifically. So this is why it's been focused on, and it's thought that somehow it's in the whole activation of the inflammatory process somehow that takes part of it. But as you saw, it's quite a high variability. So if we're measuring it 3 times in the same individual, it goes up and down. So that tells us that it might not be a really good marker, because if we're measuring it a few times and it's really different, it's not a good specific marker.
Yeah, exactly. The second question I have is about because you put a very nice cartoon about neoantigens, no, and how they modulate the what role they play in the pathophysiology of DIli. You know that in cancer immunotherapy, the more neoantigens, the better the immunotherapy works. No, does it happen also for DIli? So if you do immunosuppression, does it work better, or can it be a good biomarker? Or is there any study on this?
There's no study on this, no. So with the checkpoint inhibitors, first it was thought if you actually have checkpoint inhibitor related hepatitis, for example, this could be a hint that it's actually working really well. And this was presented, I think, a few years ago. But then I think when they did the final work of the final readout of the study, they didn't find this association anymore. But when it comes to DIli, there's no study that's measuring neoantigens and then the comparison of how good the immunosuppression would work. No.
Yeah, because you show several differences between the B220 cells and the T cells, but I think there is not a good panel of markers for this, for myeloid or lymphoid cells. Okay, Michael, you have one question, right? Go ahead if you want.
Yes, I have. Thank you very much, Sabine, for this very nice presentation, very exhaustive of all the areas that you have been presenting. One of my questions is the biomarkers that are picked up and in the clinic, they are found in samples that are at a certain time point. Shouldn't we not looking at how they behave in time? I mean, the pathology and the physiology, they are progressing, either returning or recovering or getting worse. So I think that maybe a time dependent measurement of these biomarkers would be much more scrutinizing between the different options, particularly, for example, in prognosis. That won't be very important to look at, but for diagnosis as well. What is your opinion on that? Maybe that deep learning you were mentioning in the beginning might be something to do with this.
Yeah, I think it's definitely worth looking into it, but I think it's in clinical practice sometimes quite hard, because the patients that we're including in the studies are usually patients included at tertiary centers. So you don't see them at the onset of liver injury, you see them when they come 2 or 3 weeks maybe into this. So I showed you the study that we did in drug-induced liver failure, and when we saw the different markers that could show us the outcome or not, and there we actually went to the first laboratory parameters that we had available. So we went into all the data from what the family doctors did when they first found liver injury. this is probably what we need to be doing, but prospectively recruiting patients from their first time point of is going to be really hard, because we're seeing the patients most likely too late in the whole course of it.
Right. But it might be an effort to try to follow them if they appear in your clinic, to follow them during the time that they're in the clinic and see what is the behavior of those biomarkers and trying to correlate the different outcomes. Okay, thank you very much.
Thank you, Michael. Maribel, do you have one question? I see you there.
Thank you, Javier. I would like to congratulate Sabine for this fantastic overview, that she has done across DIli, diagnosis, treatment, prognosis, chronicity, really, natural history, really fantastic, and trying to pinpoint those unmet needs, the way to move forward. It has been really very nice. You have mentioned different things that has remind me of some work that we are actually doing. For example, you have addressed DIli patients when they have autoantibodies, positive autoantibody, mainly autoantibodies beyond higher or lower the cutoff point that you have decided. Those were DIli patients in general, or just drug-induced autoimmune DIli patients, autoimmune hepatitis like?
So no, those were DIli patients in general. So we didn't.
General. Yes, you know, we also studied that, and we found that among the DIli patients, 28% of the population had positive autoantibodies. And now we are trying to see the differences between DIli without positive autoantibodies, with positive autoantibodies, and those that evolved to drug-induced, are considered drug-induced autoimmune like hepatitis, and comparing that with idiopathic autoimmune hepatitis, because we think that once the problem is that sometimes it's very difficult to know if the patient had positive autoantibodies before the DIli episode. You know, we have that information once the DIli episode has happened. It may turn negative or may continue being positive, but indeed there is no much follow-up on this population. So I think it's very interesting, because we may have some kind of a continuum of the disorder, no, of an autoimmune like disorder, no. Also, we have recently analyzed the registry, and this is regarding your findings that greater improvement in LT levels once in those patients that were DIli as compared to autoimmune hepatitis. Well, when we analyzed our final data, we saw those patients that were on corticosteroids treatment performed worst. I mean, they have higher rates of acute liver failure. And I would like to give the word to Ismael Alvarez, who is a postdoc at our group, and who has been working along with Hao, doing a very nice study using propensity matching score in order to see what happens in those populations that receive corticosteroids. Ismael.
Yes, we are here.
Oh, perfect.
Yeah.
Thank you. Could
yeah.
you comment?
Well, as Sabine, well, congratulations, Sabine, for the presentation. But yeah, as you already said, we have like a lot of divergences in the role of corticosteroids and the balance. So we performed an analysis, a propensity scored analysis, and we matched for several covariates. And we see that in a merged population from the Spanish DIli registry and another cohort from the Indiana University, that corticosteroids did not increase the risk of having acute liver failure, which was in contrast with another previous results. And then we do like a longitudinal analysis, a curve regression, and we see that in serious DIli, corticosteroids may have a positive effect and improve the normalization of liver enzymes. These results should be interpreted cautiously because we need to do some clinical trials just to test the efficacy, the dose, the time, and the tapering off of the corticosteroids.
But increase the rate of normalization of biochemical parameters normalization.
Yeah.
The same way that you mentioned.
Yeah, once patients were balanced, mainly due to their severity, there were like positive results, at least preliminary positive results.
Yeah, and we also need to keep in mind that the data that showed that corticosteroids are harmful in the really sick patients was from 2014. So this is from, it's a long time back when you're looking at ICU treatments, because they're getting better, and we might be treating the patients in the ICUs better with liver failure and maybe infections, for example, or hypotensive shocks are treated better now than 12 or 15 years ago. So
Yes,
it's hard to interpret the data from 2014 and now.
Yeah. Maybe perhaps because the more severe cases are given steroids also could be an explanation too. Yes. So I think that at the end, we still need to keep on adjudication and characterizing very well phenotype DIli patients, and follow up and collect also biological samples in order to perform of the omics studies that you have been pointing out through your talk. No, what do you think? At the end, that's what is needed, you know, in order to identify all potential biomarkers and combination of biomarkers.
Yeah, I think that is the way we need to characterize the patients really well, and have sample testings, that especially from the beginning of liver injury, and especially if we're using corticosteroids before we start them, because this will probably change the whole thing. But I think, as Michael said as well, the values, how this the biomarkers change over time, that might really be giving us a hint, because if an adaptive immune response develops, there are different stages, and if we're testing the patient at day 1, it might not be the same if we're testing him at the day 7 or 10 or later on.
So we encourage all those who are attending this conference to join us in this collaborative effort, no? To characterize to very well DIli cases, and also controls population, as we do along with collection of biological samples. It has been very nice, really, Sabine. Thank you very much for the effort put on preparing this talk. And maybe your mentor, Professor
Gerbes.
Gerbes, yes, but is he here?
Yes.
Yes. He wants to
say some words.
Well, actually, I just join you all in congratulating Sabine to this wonderful talk. And there's certainly a lot of work going into that. And it is my hope that with the joint effort of all of us who are really interested very much in DIli, we'll make a major step forward in the near future by a joint effort, because that's I think one of the major issues in DIli research is often just based on singular observations, and that is very difficult to join them together to meaningful results. So I would fully support also what Isabel, Maribel just said, so we should strive to really work together and make a step forward. And thanks again to Sabine for this wonderful talk.
Yes. We do know that we need to write a roadmap to DIli research. So your talk will be very much inspiring, no? As on this DIli research.
Yes.
In the future, DIli research.
Okay. Are there any other questions? Any other comments? I don't see anyone with a hand up. Okay, so I think then we can close this session, and then we can I invite you to attend the next Young Seminar meeting, which will be in October, the 19th of October, the third, as usual, the third Wednesday of the month at the same time, 4:30. Okay, so Sabine, thank you very much again, and it was a wonderful talk, and see you all very soon.
Thank you.
Thank you and congratulations. Yes.
Bye-bye.
Thank you.
Bye. Thank you.
Thank you.
Bye.